Hi, Mr. Sheehan here, and on this talk we'll be discussing hemostasis, or the stoppage of bleeding, and we'll look at this in 3 steps. We'll first consider vascular spasm. I need to get my pen back. And then we'll look at platelet plug formation, and finally we'll take a look at coagulation, or blood clotting. So the first step, vascular spasm, is just where the blood vessels constrict, they clamp, they spasm. And that can be due to damage, so it's a local response. It's mediated by sympathetic neurons, a reflex that causes the smooth muscle to contract. And the contraction can be maintained by platelets that release chemicals. And those chemicals are broadly classified as vasoconstrictors. And that will maintain the vasoconstriction, or the spasm, of the blood vessels to limit blood flow through the tissue. That can be significant. It's more effective with sort of crush injuries. Sometimes stimulate more constriction than a clean slice cut. But either way, vascular spasm is significant in the first step for controlling blood loss. The second step is it's referred to as a platelet plug that forms. So, picture of platelets, just a regular micrograph. They are not plate-like, like a dinner plate or a saucer. They're rather, they have lots of projections, and they can become rather sticky. So the steps that we want to look at for forming a platelet plug to fill the hole to stop the bleeding is that normally, be aware that platelets are not sticky. They're normally very smooth, very slick, and they slide past each other, normally in the blood. So they tend not to get tangled up and attached to structures. They flow smoothly through the blood. However, when there's a cut or a damage to the endothelium, so in this picture, what we're looking at is, here is the endothelium, which is lining the lumen of the blood vessel. So this is the lumen. And this is the rest of the wall of the blood vessel. So out here would be interstitial spaces, interstitial fluid, but the blood cells are flowing through the lumen. And when there's damage to the blood vessels, collagen, connective tissue, which normally isn't exposed to the lumen of the blood vessel, but when the blood vessel is damaged, that collagen can project out into the circulating blood and activate the platelets. At that point, the platelets become activated and they start to release chemicals. In particular, once the platelets are activated and become sticky, they release a number of chemicals. This is discussed in your book. ADP and thromboxane are 2. And those chemicals then circulate out in this local area of the blood, and they activate other platelets that are nearby. And it's sort of a positive feedback loop where activated platelets activate additional platelets. And they become sticky and glum together and attach to the site of injury with those collagen fibers. And they pile up and they form a platelet plug. I'm not going to worry about fibrinogen and the fibrinogen receptor between platelets. We'll talk about fibrinogen later. So that's basically the story of platelet plugs. They're normally not sticky, but they become activated at the site of injury, and they do become sticky, releasing chemicals, which stimulate or activate additional platelets to form a plug to stop the hole. That is not a clot. It just is a plug of platelets. It's temporary. And this slide shows formation of a thrombosis. A thrombosis is a clot that forms in an unbroken vessel. So the thrombus is the clot. And what this picture shows is an arterial thrombosis and a venous thrombosis. I'm not that concerned about the details of both, but just be aware that a clot can form in an unbroken vessel. On the left, it's an artery, and what they're showing is a plaque, which forms in the blood vessel, sort of in an unbroken blood vessel, and it's below the epithelium. So it's an inflammatory response that occurs and damages the epithelium of an unbroken vessel. And this can form a clot. Blood is flowing fast. We won't talk about shear flow, but it's enough to get a clot forming, which then may break off and travel through the blood. Or the plaque may just continue to grow and accumulate and pretty much start to restrict the flow of blood through the blood vessel. This is common in the carotid arteries. They tend to form plaque, and there's a procedure where they sometimes go in and open up the carotid arteries, scoop out the plaque, and seal it back up to reduce the threat of a clot forming. Because if a clot forms in the carotid arteries, it's going straight to the brain. On the right, it's just showing a clot forming along the wall in a thrombosis. These are slow flowing. The blood is flowing slower under lower pressure in the veins. Once a clot breaks off and travels through the blood and is circulating, it's then referred to as an embolus. An embolus is a circulating clot. Something else that you will encounter and you ought to be aware of are deep vein thromboses, which are abbreviated as DVTs. So a DVT stands for a deep vein thrombosis, which is literally a clot in a deep vein, usually in the lower leg. So those are DVTs, or deep vein thrombosis, or thromboses. Third step is coagulation. And it's a cascade, which means that one thing is going to stimulate another, which stimulates another, sort of like a domino effect. So this is where it gets a little bit more complicated. So we've done vascular spasm and a platelet plug formation, and the third step is the coagulation. And there's an initiation piece to this, and then a common pathway. And the initiation can occur by typically one of two ways that often occur at the same time, one being the intrinsic pathway and the other being the extrinsic pathway. So all this is referring to as intrinsic is starting coagulation from factors that are already present inside the blood. On the other hand, the extrinsic pathway is starting this coagulation cascade with factors that are normally not present in the blood. So you damage tissues, you cut tissues, and chemicals from the damaged tissues spill into the blood and then initiate this coagulation cascade. So either pathway, intrinsic or extrinsic, can begin the cascade of coagulation, but typically they both happen at the same time. So let's look at the intrinsic pathway first. And what we have here is that, again, we have exposed collagen from the rough surface, such as plaques. That was the slide that we were just looking at, where you can have a plaque form, collagen projects into the lumen, activates this pathway. Platelets start to accumulate, and the platelets are releasing lots of different chemicals. And one of them, which is of interest here, is platelet factor 3, or PF3. And that interacts with other proteins, and there are a host of them, which I'm just sort of consolidating into a single box, but there are multiple factors that stimulate another factor, which stimulates another, and ultimately we wind up with an activated factor X. And the X is Roman numeral for 10. So it's factor 10 becomes activated. Something to note is that calcium is required for both pathways. So in the intrinsic pathway, we had exposed collagen from a plaque, activating platelets. Platelets start to release chemicals that activate this cascade. Now, I'm not going into the details of this cascade, and you can thank me now or later. It gets rather complicated. If you need to look at those details, you can look them up in a book, and your textbook covers those. I'm summarizing it here. This is what I'd like you to remember. Let's look at the extrinsic pathway. Here, again, it's going to be initiated by chemicals from outside the blood, such as during a cut or damaged tissue. Kid falls, scrapes his knee off on the sidewalk. That releases chemicals into the blood from the tissues. One of these factors or chemicals is just referred to as tissue factor. Like PF3, it's just a chemical that gets released from tissues, and those chemicals activate other proteins again, and we have a similar cascade that occurs through multiple steps, and again, calcium is required for both pathways. Factor X gets activated, and then it proceeds to a common pathway. So the common pathway is everything below here, and we're going to go to the next slide. So the initiation pathways first, and the common pathway second. So here is our common pathway. So we just came from factor 10, factor X being formed above, and to the common pathway. And what happens now is that we form Prothrombinase. So Prothrombinase gets formed. It's a complex enzyme. It contains a number of different things. There are various clotting factors and chemicals, and calcium is also required here. All of this congregates, forms prothrombinase, which starts this common pathway. Once prothrombinase is formed, it catalyzes the conversion of prothrombin to thrombin. Thrombin, in turn, converts fibrinogen to fibrin. And fibrin is a protein, forms a mesh like a fishnet that's cast out and among the platelets in the plug, forms a mesh, sticks them all together, and then the mesh sort of tightens up and anchors the clot. So we've wound up forming a blood clot. The blood has coagulated. And the clot contains a number of things. The clot contains the platelets, of course, contains red blood cells that were in the area and got trapped, and it includes several other factors, clotting proteins, and notably it also contains plasminogen. So I bolded that, underlined it, and I want you to remember plasminogen. It will be important shortly. Okay, so that's the basic common pathway. Prothrombinase forms, converts prothrombin to thrombin. Thrombin converts fibrinogen to fibrin. And fibrin is the protein that glues the clot together. Then we go to the next slide, and I believe it's time for you to, nope, not quite. It's going to say practice, but we'll get there. So we made the clot. Now the tissue is healed, and we have to get rid of the clot. One thing I forgot to mention is, so let's make a note here before I go on, that most of the clotting factors are synthesized in the liver. Most clotting factors. Where's my eraser? Synthesized in the liver. Assuming the liver is working properly and functioning. If the liver is damaged, you don't make the clotting factors. Then you have bleeding disorders. Okay, so let's go back to the clot, and now you're going to dissolve the clot. The tissues have healed, the blood vessels have repaired themselves. We don't need the clot, we need to get rid of it. So this is how that basically occurs. So as the blood vessel heals, the endothelium here is all put back together, and the endothelium releases a chemical called tissue plasminogen activator, which we can abbreviate as TPA. So it's released from the endothelium as the blood vessel heals, goes into the blood, circulates in the blood in the area of the clot, and converts plasminogen to plasmin. So TPA is converting plasminogen to plasmin. Now that you have plasmin formed, plasmin converts fibrin, remember where that was, it was in the clot, or plasmin breaks down fibrin and splits it up. So TPA activates plasminogen to plasmin, and plasmin chops up the fibrin and then you have pieces of fibrin and the clot comes apart. So what does plasminogen, what's its role? Plasminogen is going to be activated to plasmin, and then what does the plasmin do? It breaks down the fibrin. So the TPA stands for tissue plasminogen activator. You remember where that comes from. That activates the plasminogen, forms plasmin, and the plasmin starts to chop up the fibrin. And then the mesh falls apart. Something to maybe note is that ogen endings, plasminogen activator or plasminogen, the ogen suffix or ending usually denotes that it's inactive. Remember in the previous slide we had fibrinogen, which is inactive. It was converted to fibrin. Okay. So here is your chance to practice. So what I would like you to do is to pause the video and have this page printed out and practice drawing it, or just have scratch paper by the side and practice drawing this common pathway for coagulation. That's what we just did. So I'm a firm believer in if you can draw it and if you can explain it, then you know it. If you can't draw it and you can't explain it, you just need to practice until you can, and then you know it. So pause the video and practice this, try it. If you get stuck, look at your notes, but hopefully you do need to get to the point where you can do this without looking at your notes. It's not hard. We'll do it again in just a couple moments after you have a chance to practice. So pause the video, do this on your own, and then we'll come back and complete it together. Okay, done practicing. Let's see what we have. So, common pathway. We had formation of prothrombinase. You could have started with the production of factor X, thrombinase, but you would have gotten to this point of having prothrombinase. And you know that prothrombinase converts prothrombin the pro also means inactive, converts prothrombin to thrombin, and prothrombin converts fibrinogen to fibrin. fibrin forms the mesh around the clot. Forms protein mesh of the clot. Remember that calcium is required at multiple steps. If you don't have calcium, you won't have coagulation. So, good job. Keep doing that until you can do it from memory. So maybe after you wake up tomorrow morning or something, try it again. The next slide is to practice the dissolution of the clot, the dissolving of it, breaking it down. So again, pause the video and practice this on your own, and then restart the video and we'll work the solution together. Okay, you're back? Good. See how was it? Let me know. I can't hear your response now, but if you get stuck, shoot me an email, get on Canvas, get some help. It's usually just a matter of finding enough time to practice, which is going to be a challenge this quarter for sure. So let's get rid of the clot. So let's start with a clot. And here is our clot. And remember what's in it. There are thrombocytes, platelets. There are red blood cells, erythrocytes, and there is a fibrin mesh, protein mesh holding it all together, and there's also plasminogen. It's trapped in the clot. So there's our clot. Okay. And then somewhere over here, elsewhere, let's pretend this is our healed up blood vessel. And so we're talking about the endothelium that's healed. And as it heals, it releases TPA. And you need to remember that it stands for tissue plasminogen activator. And TPA is sometimes referred to as a clot buster. We can talk about that in a little bit. It sometimes, well, do it now. It sometimes is administered in a hospital for a patient that has a blood clot in the brain, a stroke. If the patient gets to the hospital in time and it's not the type of stroke that's bleeding, it's the type of stroke that's formed by a clot, if they get there in time, they can be given a dose of TPA, and the TPA then does what we're describing here, where TPA then circulates into the blood and activates plasminogen in the clot and the plasminogen that's circulating. And plasminogen then gets converted to plasmin. And plasmin then cuts up the fibrin mesh. And plasmin is what breaks this apart, and that causes the clot to dissolve, and if it's a stroke patient, that restores blood flow to the brain. So practice that also. And I believe your textbook has a description of TPA in it. And make sure that you're looking at the objectives for this chapter that also cover hemostasis. The last slide of this set is a brief discussion of several common anticoagulants. So we'll just run through these rather quickly. Aspirin is a common anticoagulant. It is sometimes prescribed for people that are at risk of forming blood clots which can initiate a heart attack. So the way it works is that aspirin prevents the platelets from becoming sticky. They stay smooth, they slide past each other, they don't get sticky, they don't clump up, they don't initiate a clot or a platelet plug. Aspirin. Another common anticoagulant is heparin. We had aspirin. And heparin is both naturally occurring and, hang on, let me get rid of that. And commercially available, heparin is often used in the vacuum tubes for collecting blood. When we were looking at the slides of making a plasma or a serum prep, when you collect blood in the vacuum tubes, if they have an anticoagulant, oftentimes it's heparin. And heparin inhibits several clotting factors. And as I mentioned, it's used in some vacuum tubes. Warfarin is another anticoagulant. It is probably more commonly known as Coumadin, which is the brand name. I believe it's the active ingredient in rat poison. And it inhibits vitamin K in the liver. And vitamin K is necessary for the synthesis of several clotting factors. Again, the liver is making the clotting factors, and many of those require vitamin K in the synthetic pathway. And if you inhibit the vitamin K, you can't make the clotting factors, you can't clot the blood. For patients that are on Coumadin, the levels are very tricky to maintain. It's a very narrow concentration of this therapeutic range. If you have too much Coumadin in the blood, the patient is likely not to form a clot when they need to, and they run the risk of having a stroke or excessive bleeding. If they don't have enough Coumadin in the blood, then you're not getting the therapeutic effect of the anticoagulant, and the blood has a greater tendency to clot, and that can lead to strokes and heart attacks. So the levels are tricky to maintain. Patients are constantly going into the lab to have blood work done to check the level. Another class of anticoagulants involve binding calcium. So CPD, or citrate phosphate dextrose, binds divalent cations. So there's some terms here that I'm introducing you to. The first one is chelates or bind. Chelates just means, it kind of comes from the word of a crab claw. It binds the calcium, holds the calcium, pulls it out of solution so that it can't participate in the coagulation reactions. And if calcium isn't available, the blood doesn't clot. So it binds divalent cations, and divalent just means that we have two charges in the valence electrons. If you just remember that CPT binds calcium, you're good to go. Low calcium inhibits coagulation reactions, and it's used in blood banks with whole blood. If you donate blood at the Red Cross and you happen to look at the unit bag that they fill with blood, it has citrate in it, CPD. So it binds up the calcium. EDTA, similar to citrate, also binds cations, calcium, and is used in blood banks and some vacuum tubes. So again, we're talking about calcium. And that's it for this section. We have just a few more to do on blood typing, but that'll be the next short little series of lecture slides. So keep studying, ask questions if you have them.